myself, my name is Assistant Universitar Dr. Iacobescu George. Okay. First of all, unfortunately, as most of the things in medicine and in orthopedics, all things start with a definition. So let's start to define a plague. A plague means the lack of continuity at the skin, at the mucous membranes or on the underlying tissues that it's produced by a traumatic agent. So it's a continuity solution. This type of traumatic agents could be of types. They could be mechanical agents, they could be thermic agents, and also chemical agents. Okay, so we now have the definition. We understand what a plague is. We have the source that produces this type, or the agents that produces the appearance of the plague. We have some schematic examples. Yeah, we have an abrasion, laceration, avulsion, an incision, a puncture, and an amputation. They're just schematic. We'll continue forward to discuss more about them. As I already told you, we have some, after the definition, the next thing, it's the classification. I'll try to make you understand what's the logic of this type of classifications that we have to apply to the plagues, to the wounds, let's say. So we have one that takes in consideration the depth and the complexity of the plague of the wound. They can be superficial, yeah, or they could be deep, non-superficial, let's say. The superficial ones do not exceed the fastenings, and they are limited to the underlying skin and tissues. The deep ones subdivide themselves in non-penetrating that do not exceed the serosus, in penetrating wounds or plagues that overflow the serous but do not interest in any organ, and the last one are the perforating ones that interest one or more organs. So one of the classifications for a wound or a plague takes in consideration, as I already told you, depth and complexity. The main subdivision is superficial, and the other one, the deep ones, are non-penetrating, penetrating, that overflow the serous, and the deep and perforating ones are the ones that have interest in one or more organs. Okay, taking in consideration this type of classification, we'll have a very simple example or appliance. For instance, so you have this classification, in superficial and deep, and afterwards you have a very, very simple example, but it's very important for you. We have on the left what type of plague or of a wound. It's a superficial one, okay? And in the right one we have a deep plague, okay? It's very important. It could be very simple. This is the first thing you have to observe and correctly classify. Another classification takes in consideration the age of the wound. Why do you think it's so important to take in consideration the age of the wound? Do you have any thoughts?
Possibility of infection.
Okay, that's true. So when we are taking in consideration the age of the wound, the most important aspect that we have to have in mind, we must have in mind, it's the fatal possibility of a septic evolution. So we classify the wounds like this in recent plagues or wounds that are under 6 hours from the trauma, and there are no signs of infection present at the moment that the patient admits to the emergency room or to the physician, to the doctor. And the other classification takes in consideration the older plaques or wounds that are more than 6 hours from the traumatic agent or traumatic from the event. Okay. Unfortunately, the second aspect, the older plaques, have a high risk of possible septic evolution, a high risk of septic evolution. Okay. And another classification, it takes in consideration the degree of contamination. Also, this classification tries to tell us if there is a high risk or a lower risk of a septic evolution, because when we try to classificate the wounds, taking in consideration the degree of contamination, we have clean wounds that are only the surgical incision that are made by a physician in a specific place, yeah, in an operating room, and only by using septic and aseptic measures, yeah, and disinfected also tegument and surgical instruments. Okay, these are the only wounds that we consider clean. Yeah, the surgical incisions, they're the only ones. All the other ones are contaminated, that are all the traumatic wounds that have, unfortunately, a potentially septic evolution, more or less, yeah, taking in consideration the other aspects that we already discussed. And the last category is the infected wounds that assumes a pre-existing infection. Because when you have a patient with an infected wound, it's clear for you that it happened a while ago, yeah, and it's a pre-existing infection. Some examples for you. You have over here a clean wound. It's made in the operating room with surgical instruments, septic and aseptic measures. Let me ask you a question, for instance. Unfortunately for you, it's an anatomic related question. What is the name of that white structure that you see? It's obvious that it's what? It's a tendon. Okay. My question for you is, what tendon could it be in that region? You have two proeminent tendons. Does anybody have any clue? Come on, it's simple for you. You can search the web as we speak. It doesn't bother me. The final thing for me is for you to have in mind that the final of the micro course with some notions, even though you search them, they will stay in your mind. So what's
flexor carpi radialis?
Yeah, it could be flexor radiali carpiaris, and another possibility.
Brachialis.
I didn't hear you well. Could you
Brachialis.
repeat? You said brachialis.
Brachioradialis could be.
No. So it's a tendon. It's a tendon.
Palmari longus.
Yeah, that's true. Long palmarus. So you have two notions. Let's say I'll give you 70 to 80% of the information. There are two tendons over there in that region, in that anatomical region. It could be palmarus longus or flexor radiali carpis. One of them is more superficial, the other one is a little bit profound. One is situated in the lateral part, the other one in the medial part. If you're a little bit interested, you will search, yeah, the net, the books, yeah, the anatomy books, and this information, I hope it will remain in your, say, in your brain, in your mind, okay? Because when you try to flex your hand, you can see usually they are very prominent when you make the flexion of the hand, okay? You can see them in that region. Okay, so let's move on. We have over here a contaminated plaque Okay, it's very clear that in this situation, the septic evolution, it could be a little bit higher, okay? We have to take in consideration the age of the wound, the degree of contamination, and so on, when you want to correctly sterilize the type of wound, okay? And in this image, you have a pre-existing infection. It's very clear that it's an infected wound, okay? Okay, so let's move on. Unfortunately for you, we have to describe a plague management. This plague management takes in consideration some few steps. There are 9 steps over here written. We'll discuss about each one of them. I don't want to overflow you with a lot of information, let's say unuseful information that you'll probably forget in a few days or weeks, let's say. But I'll try to make you understand the logic of this algorithm of the plague management. So when we want to address a wound or a plague, the first thing is to correctly examine the wound. When we examine the wound, taking in consideration all the aspects that we already discussed in this micro course, you'll have to correctly classify it. Because when you correctly classify it, you'll know what to do in the future. Okay, in the future, I mean to the next steps that you have to address. If it's a superficial wound, you have one type of management. If it's a more profound, a more deep wound, you have a different type of management. If it's a very early wound, the risk of infection it's a little bit lower. If the time from the traumatic agent and the presence of the patient in the emergency room, it's very long, the risk of infection it's higher. So you have to take in consideration. So this is the first step. It's to correctly examine the wound and the patient. The first step in medicine. You never put a diagnosis without the examination of the patient or the wound. Yeah, this should be, I don't know, a strict rule for you. Okay. The next step is wound dressing plus anesthesia. The third step is the hemostasis. The fourth step is the debridement. The fifth one is the closure of the wound. It says plus minus because if it's possible, you'll see that in not every situation the primary closure of the wound is possible. Drainage, if you consider it, antibiotic treatment, band-aid, and a few tips about a correct band-aid, and the anti-tetanus prophylaxis if it's necessary. So let's start with a few things about the examination of the wound. It involves the observation of the depth, appearance, complexity of the wound, presence or absence of foreign bodies, the degree of contamination, and the presence of tissue necrosis. So this is the steps that you have, the first step that you have to correctly examine the wound, okay? The second step, it's anesthesia. Well, you see, anesthesia submits itself in more categories. The first one is the local type. It requires an infiltration with lidocaine in some 0.5 to 1%, or bupivacaine plus minus adrenaline. Unfortunately, I already told you the observation, but let me ask you like this. What is the role of adrenaline when we want to address a wound besides the local anesthesia composing of lidocaine or bupivacaine? Doesn't matter. What is the physiopathological role of adrenaline when we want to use it?
To cause vasoconstriction, because
it's correct. So we want to have a vasoconstriction. It's pretty smart, okay? So you make the anesthesia, and besides the anesthetic, you also inject adrenaline. Well, by injecting adrenaline, you have vasoconstriction, and this way you prevent the loss of blood, and this way you can address the wound more properly without a lot of blood contaminating your your field of work, let's say. But be very cautious, because when you want to do, let's say, smart stuff to help you and to be better in what you do, there could be also some negative effects. Because when you use adrenaline for lacerations that are present in the nose, fingers, ears, or let's say penis, all the extremities, unfortunately, that could be appear a necrosis, tissue necrosis by vasculospasm. So be very, very cautious when you choose to use yourself with adrenaline, not to use it in body extremities. Okay, it's a very important thing to, because, for instance, a patient comes to you with a wound at the finger, you make a local anesthesia, you also insert adrenaline, everything seems perfect. Yeah, you address the wound, you bandage it correctly, and the next day when for instance, the patient comes to the emergency room, you'll see an extensive necrosis. Yeah, with also possibly the loss of that finger. So you try to address one little problem, and the consequence could be a bigger problem. So be very cautious when you want to. Every medical gest that you do has to be very well thought. Okay. Another type of anesthesia is the truncular one. It is practiced when the nerves that reach the wound are located relatively superficially. An example is the collateral nerves of a finger. Okay. And the last type, it's the general anesthesia. It's used for broad wounds that are on large surfaces. Usually they are used for penetrating or perforating wounds. So this is the reason why you have to correctly observe and classify the type of wound, because you cannot use local anesthesia, for instance, for a perforating wounds or a penetrating, because the pain will be very high for the patient, and you won't be able to address that wound. Okay. Moving on, the debridement. Well, the debridement consists it's the most widespread method. It consists in removal of foreign bodies, devitalized tissues, and also the bacteria from acute or chronic plagues. It's true that its application improves the local defense and reduces the evolution of infection, and it promotes the healing. The debridement process, it's also classified in different types. It's a surgical debridement, mechanical debridement, autolytical debridement, enzymatic debridement, and chemical debridement. We'll discuss a few things about each one of them, yeah? And I'll try not to just to pinpoint you the most important things that you have to remember. So the debridement, as you can see in the picture, is the one that it's the most efficient. You have, depending on the type of it, to use specific measures. So let's start with the surgical one. There's a lot of text over here, and I'll try to pinpoint you the most important ones. You see the surgical debridement, as its name says, it's made with specific surgical instruments, okay? Scissors, scalpel, yeah? You have to remember that it's performed under aseptic condition in an operating room and under the effect of an anesthetic. And this type of procedure, it's only made by a surgeon. It consists of in the excision of necrotic tissue from the plague, compromised tissue, and also it's very important to take out the edges of the wound, because unfortunately they have a high risk of necrotic evolution. Also very important is to remove the biofilm. Do you have any clue what the biofilm refers to, or this term what it tries to define, the biofilm? You will more frequently use this or hear this type of thing, biofilm. Nobody?
Is it like vegetations?
I didn't know. More louder if you can.
Is it like vegetations living on the wound?
Not precisely. Let's say it's an aggregate of microorganisms that stick one to each other, and they stick to a surface. Usually, this biofilm is made of the bacteria layer that it's present on the superficial plane of the wound. Okay, so this is the reason why it's very important to remove this biofilm. The mechanical debridement refers to the application of an external force to remove the necrotic tissue, and can be done with wet dry dressing, irrigation, hydrotherapy, hydrosurgery, or ultrasound surgery. Okay, autolytic debridement. Well, key point for you that it's the refers to the use of the enzymes that are produced by our body, their collagenases and proteases, and they have the role to rehydrate, soften, and liquefy the necrotic tissues and the scars, and to remove them from the viable tissue. These types of proteolytic and fibrinolytic enzymes work only in wet environment. So this is the most important thing that you have to remember, that we have to apply wet dressings that promote this type of autolysis. The enzymatic debridement consists in achieving, by means of preparations, this type of enzymes that our body naturally produce from exogenous origin, and they're also applied to the necrotic tissues to potentiate the role of the enzymes that our body also produce. Okay. The chemical debridement consists of in the use of chemical substances to debride the plague. We can use antiseptics, silver preparations, solutions of sodium hypochlorite, caustic agents, and antiseptics. The closure of the wound or the healing, it's of different types. It can be primary delayed, and secondary. So let's talk about the primary healing. It's the first healing phase, and it's defined as the surgical closure of one or more layer of the wound within a few hours of its occurrence. Usually, most of the surgical incisions are primary healing, and you can close them in this primary phase. Okay. Another type, it's primary delayed healing. It's very used, and a good example for you is the fasciotomy incision. This primary delayed healing consists in a surgical closure of the wound within a few days to a maximum of 1 week from its occurrence. You have to know that the granulation tissue must be removed and the wound edges excised to prevent the necrotic evolution. Let me ask you a question. When do we as surgeons are required to make a fasciotomy incision and to apply this primary delayed healing? Yeah, so not to be able to primary close the wound in the primary phase.
Compartment syndrome?
Correctly. So when we have a compartment syndrome, due to the accumulation of the pressure in this in that specific compartment, we have to make some fasciotomy incisions to let out the pressure from the compartment, and we cannot primary close the wound. Unfortunately, we have to let it open to a maximum period of, let's say, 5-7 days. Okay, so in this type of problem, of syndrome, compartment syndrome, we have to apply the primary delayed healing. The secondary healing is a more complex situation. Is the option that remains if the wound cannot be repaired primary surgically repaired. This does not mean that the surgeon can let the wound heal itself, because you have to understand daily care is needed. You have to make a specific connection between the patient and the medics, the caregiver, and it's a long-term commitment. Usually, these secondary healing situations are applied to open fractures when we have a lot of soft tissue missing, extensive delaceration of the tissues, and it's impossible for us as surgeons to primary or secondary primary delayed healing or closure. So in this process or in this situation of open fractures with a lot of soft tissue missing, we have to apply the secondary healing. In this long-term commitment, the caregiver has to clean the bacteria, the biofilm, the daily toilets, the necrotic tissues have to be taken out. We have to use a lot of antibiotics, and it's very hard. Okay, you have to understand that it's very hard. We have to observe the form of new tissue with granulation, contraction, and epithelialization. There are some specific surgical, let's say, options that we have. We as orthopedics usually don't do this type of stuff because we are helped by the plastic surgeons, but we must have in mind what types of surgical options we have, or the surgical plastic surgeons have. One of them is the skin graft, and you have to correctly address the type of wound or the type of extension of that wound to know what type of surgical option you have. The drainage. Well, the drainage allows the secretions to be evacuated from the wound. The logic of the drainage is not to let the secretions, blood or pus or what will drainage from that wound to accumulate in that cavity, so it could be a septic evolution. Okay, so this is the reason why we have to use the drainage to prevent the accumulation of the blood and pus. The Band-Aid. Well, it's important for you to know that the Band-Aid for suture wounds has to be sterile, dry, and watertight, and usually has to stay for more than 48 hours. But for open wounds, as I already told you, you have to use a wet inward and dry outside type of wound. We can use chloramine and hydrogenated water to wet the inward part of the Band-Aid. But why do you think it's very important the interior part for the open wound, the interior part of the Band-Aid to be wet? I already told you. Because when we discussed about the enzymatic debridement, I told you that there are some specific enzymes that have to operate in wet environment, okay, to be efficient. So this is the reason for open wounds we have to use wet inward Band-Aids, okay, so not dry. The antibiotic treatment, it's used in contaminated wounds or in wounds with a massive tissue destruction or in patients that have immunodepression at the presence. Usually, when we don't have an antibiogram, we will use a broad spectrum antibiotic that should be administered. In all other situations, our antibiotic treatments should be targeted in a correlation with the antibiogram. Okay? Antitetanus prophylaxis is usually used in the wounds that are older than 6 hours for contusions or stings, and the wounds that have a high contamination. Thank you. If there are any questions or some other unclarities,